neurology and the stroke program at PSouth Southwest will be here at 10, and she has an hour window to do her section, so I have to get rid of my section before that time. So as you know, that may be very difficult with me. We're going to talk about stroke today. A reminder on the board, March 13th at PSouth is the trauma case review. Breakfast is served at 7:15, and it's actually pretty good. Dr. Timmons, you recall Dr. Timmons, she's the paramedic become trauma surgeon. She'll be providing the case, and it's a traumatic brain injury case, one of the cases that you guys brought in. So, yeah, okay. So, I'm going to go very fast through a lot of this stuff. Stroke. We're going to do stroke didactic this month. Next month in the skill sessions, it'll be stroke practice. Not that you get to practice having a stroke, you get to practice dealing with a stroke. You can practice having a stroke too, and then we can work on you. Stroke kills about 130,000 Americans every year. And that's out of about 800,000 stroke victims per year in the U.S. Most of these are new strokes, but that means that 200,000 people have a repeat stroke every year. Now, 87% of all strokes are ischemic strokes. Stroke is the leading cause of serious long-term disability. Interesting slide here showing stroke death rates by adults age 35 and older by county in the United States. The really dark ones are the counties you don't want to live in. Because, yes, yeah, but that deep fried catfish will go down really good, you know, but you won't be able to swallow. Now, looking up in here, so we're in the pretty good stroke areas. Now this is adjusted for county. This is adjusted. It's always we do medical occurrence rates by either 100,000. Usually it's 100,000 population. That's what this is. And obviously, when you get to Skamania County, there's not 100,000, but they do a mathematical adjustment as if there were 100,000. So, Skamania County. Now, why are some of these purple and not? Well, probably because they're long ways away from medical care. Probably because they don't recognize that they're having a stroke. One of the problems with stroke is just like it used to be with a heart attack, is people have to recognize the symptoms. So the Heart Association, Stroke Association has been really pushing on that. Now, surprisingly, I'm really surprised that Arizona has such a, because there's so damn many old people there. I don't know. You know, but maybe they're already, you know, you can't tell if they had a stroke. I don't know. So, now, ischemic strokes. Now remember, 87% of all strokes are ischemic in origin. They're either occlusive from a thrombus. Usually a thrombus comes from someplace else. It can occur de novo, but in the brain it usually comes from someplace else, like from atrial fibrillation and a little clot off the valve. Or it comes with thrombosis off the carotid if the carotids have partial occlusion due to plaque. And so, I mean, that's an embolic stroke. So a thrombus can occur right at the site if you've got low flow and hypercoagulability. Low flow and hypercoagulability happen when you get to be old. The anterior circulation is the part of the brain that's provided its blood supply by the carotids. And the internal carotids serve the cerebral hemispheres. The posterior circulation is the vertebral basilar circulation. It comes up the back, and it starts to serve the brainstem and the cerebellum first, and then communicates with the circle of Willis. We've got a picture later on. Hemorrhagic strokes come in two basic flavors. Either subarachnoid hemorrhage, which from an aneurysm, most common an aneurysm. Also arteriovenous malformations. You're born with a defect that causes the artery and the vein to interconnect without having a capillary system in between. So all the pressure of the artery is directly goes into the vein, which is very pliable, and it expands and ultimately ruptures, and you have essentially same thing as you have with an aneurysm then. Then there's intracerebral bleeding, hemorrhagic stroke. Hypertension is the most common cause, so generally with older persons or persons who have long-standing hypertension. And then in the elderly, there's a degeneration of the artery called amyloid angiopathy, and that can rupture then to it's a weak vessel. Now, there's a few risk factors for stroke. Some are you can change, some you can't change. You can't change your age, you keep getting older. I mean, that is the best alternative. You can't change your gender. You can try, but you can't change your genetic gender. Race, blacks, Latinos are a little bit more likely to have hypertensive bleeding strokes. They're more likely to have diabetes. Previous CVA, once you've had a CVA, a stroke, your risk factor is doubled or tripled to have another one. You've already proven you can have one. And then heredity. There are certain things like the propensity to amyloid angiopathy would run in families. Things you can modify. If you're hypertensive, you can change that. You stop tobacco. Tobacco increases your risk of stroke about threefold. History of TIAs. If you have a history of TIA, if you became blind one day in one eye and then all of a sudden, and then it went away, you really should get worked up to find out where your stroke's going to come from. Heart disease, obviously AFib. There's a bit of controversy right now because after the age of 75, people who are on atrial fibrillation, we commonly have them on Coumadin, and now the newer anticoagulants for a number of reasons. But this is to stop the possibility of an embolic stroke from that valve. After age 75, you begin to have a risk-benefit issue that your risk of falling and having intracerebral bleed from being anticoagulated is probably greater than your risk of having a stroke if you haven't had a stroke up to that point. If you don't have diabetes and you don't have hypertension, probably there's a thought that we maybe shouldn't keep you on anticoagulants after age 75. Now, other things, if you're hypercoagulable, you have a chance, more likelihood of having a clot. So if you have, and things like pregnancy, cancer, recent surgery increases the risk of de novo coagulation. And so you could end up with a stroke. So you can adjust that by, when people have had surgery, we often keep them on Lovenox or an anticoagulant for a while. Even aspirin therapy is effective. Sickle cell disease, which is very rare around here. If you have a history of carotid bruit, that means you've got plaque and you've got a narrowing of your carotids. It's the thing we're supposed to listen for. Remember when you're going to do a carotid sinus massage, which we don't hardly do anymore, as a vagal maneuver if you're treating someone with PSVT have to listen to make sure they don't have a bruit, because older persons with a bruit, you sort of rub on that and you can break the plaque loose and the stroke will right on the spot. It means, however, that with the narrowing, with the bruit, you've got a narrowing, you've got a risk of a stroke that needs to be taken care of. Now, in ischemic strokes, and we're going to talk mostly about ischemic strokes, it's involved, so if your stroke involves the anterior circulation, the carotid circulation, this is characteristically, this is where the stroke presents as unilateral paralysis on the opposite side from the stroke. So you stroke on the left side, you're paralyzed on the right, because there's a crossover at the, as everything leaves the brain. You have numbness also on the opposite side of the stroke, but it's on the same side as the paralysis. If you stroke in the hemispheres that are involving hearing and language, so mid-temporal, you're aphasic, which is difficult comprehension, nonsense speech, difficulty in reading and writing. They can read, but they can't articulate what they read. Dysarthria, slurred speech, abnormal pronunciation, and then you can have visual disturbances with strokes in the anterior circulation, carotid circulation, and monocular blindness on the same side as the stroke. That's from an occlusion of the optic nerve, basically. That eye becomes blind. Now, in the vertebral basilar circulation, primary symptoms are going to be vertigo, visual disturbances, because it's supplying the occipital cortex, so both eyes are affected simultaneously. And because of often at where the nerve, where the nerves pass out of the optic chiasm, you can have, in the brain, you can have diplopia, because one eye is basically somewhat palsied, somewhat paralyzed, so it moves out of sync with the other one. It develops central diplopia. Or disconginate gaze. It's asynchronous movement. We all know about disconginate. We see disconginate gaze often after seizures, but also after strokes. And that's involving the vertebrobasilar system. You can also have paralysis, numbness, dysarthria, and ataxia, because the posterior circulation and the anterior circulation communicate with each other in the so-called circle of Willis. Willis was a neuroanatomist who described this, so that you have, if your vertebral basilar system is plugged up, you can get some collateral flow back through the circle of Willis and feed anterior to posterior. And the same work, if you have, your anterior carotid is thrombosed, you can get circulation from the other side and from the posterior circulation. That keeps us going most of the time. Hemorrhagic strokes, subarachnoid hemorrhage. The symptoms of subarachnoid hemorrhage may be sudden, severe headache. Now, that's the classic, the so-called thunderclap headache. It happens so suddenly. And it's also always described just like the migraine patients always come in and say, it's the worst headache I've ever had. Well, it's not in their case, but this is the worst headache you'll probably ever have. Transient loss of consciousness may be, so sudden severe headache associated with decreased level of consciousness or actual collapse is pretty, you know, that's an ischemic, that's a subarachnoid hemorrhage until proven otherwise. Often associated with nausea and vomiting. You're Brain doesn't like blood in there. It's not supposed to be. It's supposed to be inside the vessels, not in the subarachnoid space. Neck pain because the meninges are irritated. So you get like meningismus, you get like the pain you get from meningitis. Intolerance of noise and light. It's sort of like, that's how it's sometimes confused with migraines can be confused with that. That's why we pay a lot of attention to people who say they have this sound and light intolerance and severe headache and all that. And even though we know they probably have a migraine. Altered mental status. Now, the characteristic of subarachnoid hemorrhage, if you're lucky, is that you have a herald bleed, a premonitory bleed. You'll have a minor subarachnoid hemorrhage that gives you severe headache, some of these symptoms, and then it seems to be getting better. And that's nature's way of telling you to go in and get a CAT scan and a few other things, because you're going to have a big one after the fact. It's going to happen again. So our job is to work them up very quickly from that. Now, intracerebral hemorrhage, whatever symptoms you have depend on where it bleeds in the brain. So if it's in the temporal side, then you're going to have the same thing as you have with an ischemic stroke. Aphasia, loss of maybe paralysis on one side, numbness on one side, maybe sudden collapse as well. A lot of things we consider in the differential diagnosis of stroke. Head and cervical trauma. Obviously you have to, no, so it's a confusing thing if you have somebody you find someone old who's down, they've fallen, you don't know if they hit their head, hurt their neck on the way down. We have lots of old people with, and by old people now we mean more than 55. A couple of us here. But yeah, you don't know if they we have lots of older people who break their necks, who have intracerebral bleeds because of the medication they're on. So you have to protect their neck. Meningitis, encephalitis can cause symptoms of a stroke because the brain is infected. Hypertensive encephalopathy, you can have stroke symptoms without having the stroke yet. We know that. That's why we treat some persons who have hypertensive encephalopathy but who don't have focal neurologic finding. We don't bring their blood pressure down quickly. If someone has just confusion, no focal neurologic findings, and they're frankly hypertensive, we try to lower their pressure slightly to improve that. Intracranial masses, tumors, epidural and subdural hematomas can cause stroke symptoms, but direct pressure on the brain essentially is causing ischemic stroke symptoms by compressing the blood vessels. Now, Todd's paralysis is an interesting thing. One of the differentials is if patients had a seizure, then they will have this is a brief temporary paralysis on one side of the body, essentially stroke-like symptoms. Seizure, paralysis and numbness on one side of the body. Now, it says brief, but I've seen it go for 3 days. Now, how do you know that? So what we do now is we do more evaluation, and we don't use TPA on someone who has had a seizure at the same time their stroke symptoms presented. So if the patient has a history of this, has had a seizure, if the bystanders say, you know, he was jerking and twitching and he was unconscious briefly and then he seems to be paralyzed afterwards, we will not use TPA on that person. They will get further workup to determine if they really do have a stroke or if this is Todd's paralysis, because we don't give TPA just for fun. Migraines can cause, you can have a paralytic migraine, they can be paralyzed on one thing, you lose vision in part of their visual field. So migraines are one of the rule out if they have stroke symptoms. Then there are metabolic problems. Hypoglycemia can cause stroke symptoms. Hyperglycemia to some extent, but hypoglycemia certainly can. People can be semi-comatose and have decreased, and they can essentially have paralysis. Post-arrest ischemia, so we don't generally TPA people who you've brought in because you've got ROSC and they're not moving one side. That's probably just because they've had a little ischemic brain effect for that time period. Drug overdoses. Well, they're not truly paralyzed, but they're paralyzed, you know, from the drug overdose. There's a differential, there's a little mnemonic that we use for the differential diagnosis of strokes. It's AEIOU and TIPS. Basically, alcohol, endocrine, epilepsy, encephalopathy. There'll be a test at the end on this. Infection, including sepsis, opiate overdose, any other overdose, uremia, renal, end-stage renal sepsis, if you will, trauma, insulin, hypoglycemia, hyperglycemia, poisoning, psychosis. Psychotic people can act like they've had strokes. And then stroke, seizure, and syncope, even after syncope. So, our stroke chain for survival is detection, early symptom recognition, which is why the Stroke Association goes, you know, has public service announcements and things, and they go through, if you've seen any of them recently, they go through showing people who have what we use, you know, the Cincinnati Stroke Scale to evaluate at home. To say if you have, you know, facial droop and slurring of your speech, you know, call 911. Don't wait. Don't call your daughter who lives in Arizona. Dispatch, prompt EMS, we've got that down. Delivery, transportation, appropriate pre-hospital care, pre-arrival notification, and then because the mainstay of early onset stroke now is, if it can be treated at all, it's going to be treated with TPA in that first 3.5 hour window. Then we want rapid door data and decision to make to do TPA or not. So rapid decision making. Now, recognition, we have public education of stroke symptoms, early access to medical care. You have early, and we have early dispatch and pre-dispatch instructions. And they've been training the EMDs, the dispatchers, to recognize stroke symptoms more. Matter of fact, they go through a modified stroke scale with some patients now. Our patients are improving. This shows the areas of the state. This is 2 years ago that were the initial signed up initially to all the hospitals and dispatch systems to this early stroke network through when the law was written 2 years ago that required stroke hospitals. And stroke hospitals, if you say you're a stroke hospital, you have to prove that you can be a stroke hospital. Now, for us in EMS, we do the FAST exam. Face, normal, equal bilateral movement, abnormal, unilateral weakness or drooping. Arms, normal. Both arms move equally or not at all. Abnormal means one arm drifts compared to the other. Now, ideally, your patient is sitting up, at least in a semi-Fowler, and hands are out, palms down. Close their eyes. And if it drifts away, that's positive. That's abnormal. That's a drift. Speech, normal speech. Abnormal, slurred speech, inappropriate words, incomprehensible words. And then the most important thing is establish time. Onset of symptoms or last known well. If they wake with the symptoms, we say now that, at least with P-South Southwest, we'll say that that's the onset of their symptoms. It actually turns out probably to be so. That's what wakes them up, is the stroke. Now, if you get there and the person is down on the ground, down on the floor, they can't move one side and they're drooling from the thing, you don't have to do the FAST exam. That's already positive. You don't have to sit them up. Now, stroke. The person I just described, which you've all seen, they have potential airway problems because they can't protect their airway. There's some paralysis, often of the upper airway. If they're drooping on their face on one side, those muscles in their throat are also somewhat paralyzed. They may be vomiting, especially if they have a hemorrhagic stroke. They may be in a coma, so they can't protect their airway. They may be actively seizing while you're there, and they may have cervical trauma. So they need oxygen if they're under 94%. They don't need oxygen if their oxygen saturation is 98. Matter of fact, that may be contraindicated. It is contraindicated in a stroke, just like it is with a STEMI. You don't need, or especially with ROSC, you don't need 100% oxygen because you don't know how much that really is, and oxygen toxicity in an ischemically damaged brain is not good for you. They need an MPA or an OPA if they can tolerate it. Suction is needed. Put on the paralyzed side if you don't have to protect their neck, or if you can protect their neck even in that side so they don't aspirate, or they need to be intubated to protect their airway. Your job is to protect their airway. If you think it's an intracranial bleed, and if they're showing any signs of Cushing's triad, hypertension, slow heart rate, erratic breathing, then keep their CO2 at about 35 max. They may have irregular breathing pattern, chain Stokes, central neurogenic hyperventilation. So, and they may be paralyzed. So you may have to aggressively manage that. Circulation problems with a stroke. Potential problem, hypertension, hypotension, and dysrhythms. Their hypertension, don't lower their blood pressure in the field. Don't attempt to lower it with nitrates or anything, because they've already got focal neurologic findings. They've got a stroke. You lower the pressure, you basically lower the intracranial pressure, and you have the more expansion of whatever it is that's the stroke is causing, either edema or bleed. If they're hypotensive, we try to get their target blood pressure up to about 100 to 110. Certainly above 90, just like you will with stroke, with trauma. Treat dysrhythms as needed. AFib is common, but they usually are in, all you do is look at their medications. They're on Coumadin. You know they've been on AFib. Don't try to convert the AFib. We don't shock them unless they're, well, I suppose if the problem is that if they're ticking along at 200 in AFib, we might have to treat that. And treat that the way you would any AFib. If it's emergent, it might have to be shocked. Otherwise, we'd probably use diltiazem to slow it down. So, dysrhythms as needed, IV access, correct hypoglycemia, and prompt transport. Now, in this county, we're now changing this a little bit, so listen up to this one. This will be a slight change to your orders, very slight, and I'll identify where it is. Transport emergently, code 3 transport, if the patient, and call in, say, I'm coming with da-da-da-da-da, code 3 stroke. Now, so emergently, if there's less than 8-hour onset, less than 8-hour onset of aphasia, facial droop, unilateral weakness or paresthesia, inability to understand, verbalize, understand, loss of vision in one eye or the visual field, vertigo, sudden onset, persistent, progressive with headache, and or they went to bed normal and woke with the symptoms. We'll still call that within 8 hours. That's code 3 transport. So acute stroke symptoms, less than an hour. The destination hospital, we're going to go through the thrombolytic. If they fail the thrombolytic checklist, if you have time to do the thrombolytic checklist and they fail it, they go to Peace Health. If they're 80 years or old, Peace Health. Symptom onset, 2 to 8 hours, Peace Health. Suspected intracranial hemorrhage, Peace Health. Symptom onset less than 2 hours. Closest stroke center could be Legacy or Peace Health or the patient family choice. Symptom onset greater than 8 hours, closest stroke center or patient family choice. Beyond 8 hours, they're probably not going to get intervention or and they're definitely not going to get TPA. The reason it's the 2-hour thing is when you get to the scene, when you make first patient contact, you know you're going to take at least 15 minutes at the scene. I say at least, that's what you're supposed to do, is 15 minutes at scene. And the average around here in town is going to be 15-minute transport to the hospital. So that's 30 minutes off the thing. Then we get 45 to, I know how things work. It takes about 45 minutes to an hour to get the CT, to get all the labs back, to get the CT read, to get the neurologist to evaluate the patient, and to get the drug up from the pharmacy to start TPA. So if the patient fits the criteria to be able to have TPA, that's an hour and a half gone already. We have a 3.5-hour window. So you get to have 2 hours on your end to say, yeah, I was normal at 7 o'clock, it's now 9 o'clock. You mean, okay, you can boogie. You can go to either hospital at that point. If they say, gosh, you know, I woke up at 7 o'clock and I was okay, and at 7:30 I started having, you know, I was eating and I started drooling and dribbling my food and I couldn't move this side, and now it's 11 o'clock. It's out of the window for easy TPA. It means more evaluation. It means the neurologist has to do more testing. We have to do more CT, and they may go to an intervention. Peace Health is where you can do intervention. Intervention means intra-arterial TPA or intraarterial removal of the clot with a type of clot extractor. So it was a lot easier when there was only one hospital, but look at that 2-hour window. That's what you need to take them to either hospital. If it's within that 2-hour window, that's fine. If it's beyond that 2-hour window, they should go to Peace Health because that's where we can do intervention. Yep. Stroke centers in Portland would be primarily Providence and, well, actually the main stroke center in Portland, the one that Peace Health refers to when they have an interventional case, is OHSU. But both Providence and Legacy, Good Sam will do interventional stuff as well. And, yeah, they all say they do, so, but I mean, you're not going to drive all the way to Meridian Park. Emmanuel can certainly do. Now, they may not be able to take an acute stroke you'll have to call and see on the cath lab. What happened in Portland is everybody decided they wanted to play. And that's not a good system, but that's another story. Yeah. Yeah, Prov Portland. And if you wanted to go all the way to Prov St. Vincent's, but that's that takes you out of service for a little while. Now, this is the thrombolytic checklist, and I have to do a little addendum up here. This does not, quote, exclude the patient from, but this excludes the patient from going to a place where they can't do intervention, because if they fail any of these things, then they need more evaluation by the interventionalist, because they still may be able to get TPA if they've had a hemorrhagic stroke in less than a year, depending on what their CAT scan and the CTA would show. But they need more time to do that. It's going to take more time. They may need an MRI at the same time. So, so these are the kind of things that would rule you out for going to a place that's only going to use TPA, that has the ability to use TPA. So. Hemorrhagic stroke recently, intracranial pathology. No, they have to tell you that, or someone has to say, yeah, they fell down and they whacked their head and they had a fracture and they bled into their brain a little bit, but they seem to be okay now. Active internal bleeding, not menstrual period. Suspected aortic dissection. Well, that's hard for you to suspect. Chest pain, tearing chest pain. Radiating to the back, associated with a stroke symptom, that could well be an aortic dissection. That has to be worked up, but you probably want to take that to a place where you can do major workup. Uncontrolled hypertension, current use of anticoagulants, and we have a case. I think we're talking about that. Well, there's a recent case I know that we couldn't use, that they couldn't get TPA because they were too anticoagulated from their medication. Recent trauma, major trauma, not I fell down and sprained my ankle. CPR, prolonged, major surgery, recent internal bleeding, known allergies, jaundice, hepatitis, kidney failure, which we would work up. That would not necessarily exclude them, but they need probably interventional stuff. And terminal illness and pregnancy, we probably don't. That's the decision of the patient, the family, and the specialist. But you probably want to be at a place where you can have major intervention if you need to. Remember, the stroke team is going to need more information, usually medical aids, particularly if the patient's not conversant or if they have aphasic speech. So we want the patient present, if the family present if possible. if it's not feasible to bring a family member in with, get a phone number that and tell them to stay by the phone. Critical actions for you: assess and support cardiorespiratory function, assess and support blood glucose, assess, support oxygenation and ventilation, assess neurologic function, you're fast, determine precise time of symptom onset, determine essential medical information, emergent transport to the appropriate ED, and notify the ED that a possible stroke patient is en route. Code 3 stroke. Now, when you get there, you should be met by the nurse and the ED physician within moments. The problem now, because your code 3 stroke will go out as a code 3 stroke page, but it will not become, at least at Peace Health, will not become a Neuro 911, which is our code for calling the whole team. So you get a small team, you get the ED doc, the nurses, and lab techs. CT is put on standby, and the physician will do the initial evaluation, and the initial, his or her initial evaluation is much more complicated than yours, and it's more refined to sort out whether this is truly a stroke or not a stroke. They may then call this a Neuro 911, which steps the process up and gets the stroke neurologist involved. Now, often the stroke neurologist is in the department at the same time, and they'll just walk over from whatever they're doing when they hear a code 3 stroke. They may then say, no, this doesn't fit for whatever reason, this doesn't fit Neuro 911. This patient will not get TPA. We need to do further evaluation and possibly interventional stuff, but they'll work that out. In the ED, in the first 10 minutes, they're going to reassess the ABCs, vital signs, provide oxygen as needed, IV access if you didn't already have it, get the blood samples for CBC, electrolytes, and the coagulation studies, whether they're on or not on anticoagulants. Get a 12 lead if you don't already have it. You probably have it. They'll get another one. Put them on a monitor. Check the sugar if you hadn't done it before. Alert the stroke team. And they're going to perform a general neurologic screening assessment. And this is I'm just going to explain this one. You're not expected to know this one. We haven't taken this out to the field yet because it's quite involved, as you're about to see. This is the National Institute of Health Stroke Scale, NIHSS. Provides a quantitative measure of stroke-related neurologic deficit, and it's something that you can compare so you do it at different times, and you compare the results as you're going along to see if the patient's improving, staying the same, or getting worse. And there's good interrelator correlation here, which means that if I test you and come up with an NIHSS score of 8, that means one of my partners will test you and come up with a 7 or a 9, and so it's close. Or they'll come up with an 8. It also predicts short and long-term outcome. And we use it as a data collecting tool too. It's 11 items. And number 1A, level of consciousness, and it goes from 0 to 3. 0 is alert, keenly responsive, and 3 is responds only with reflex motor or autonomic effects to stimulation. So they're basically unresponsive or flaccid. Not good. Level of consciousness questions. Ask the patient their age and current month. 0 answers both corrections correctly. That means you have to know both their age and the current month. And 2 answers neither correctly. 1C, commands. Level of consciousness, commands. Ask patient to open and close eyes, grip and release the non-paralyzed or weak hand. So they follow commands, or they don't. Best gaze, that tests your horizontal eye movements. So they follow the light or the pencil. 0 is normal. 2 is deviation or gaze paralysis. One eye doesn't track. Visual fields, we have to test, you know, like they do when you go get your driver's test. You look in the thing and well, we just test it. Okay, can you see my fingers wiggle? Obviously I can't until I get out to about here. Okay, right there. You test gaze up here, test visual field here. So it takes a little time. This is an important one because people often will be otherwise okay, but have a visual field defect. So 0 is no visual loss. 1 is partial sector loss. You're losing some. 2 is a complete loss on the sides, or completely blind, which is quite a significant field loss. Facial palsy, oh, we're getting into the fast testing here almost. Show me your teeth, raise your eyebrows, close your eyes. 0 is normal movement. 1, minor paralysis. 2, partial paralysis of the lower face. 3, complete paralysis of one or both, one side of the face or both sides of the face. 5 and 6 are motor, arm, and leg, and so we're getting into fast test. Extend the arm. 0, no drift. 1 is drift. 2 is drift, but the patient can resist gravity. 3 is a limb falls. They have no effort against gravity. And 4 is no movement at all. And then we do a further addition of limb ataxia. They do the finger to nose test. You move your hand about a little bit and they finger to nose. If you fail it, you do this. You know, you miss. You know, if you have a big nose, it makes it easier. And then you do a shin test. Put your heel on a shin and you go all the way down to your foot. People with ataxia cannot do that. So, once again, 0 to 2. That tests the cerebellum. It's really, we used to sit them up and make them walk, but they'd fall over, and that was not good. Sensory. Pinprick sensation. 0 to 2 again, total sensory loss. Patient is not aware of being touched, face, arm, leg. Usually it's in the same place that the paralysis is. Best language. Now these are fun. Name all the objects on the card, read all the sentences, and describe what's happening in the picture. Well, that's for these ones here. So they have to describe what's happening in this picture, which is trauma about to happen. Describe all these objects, and read all the sentences. I had to get the sentences here. So these are the sentences. Then there's another one. Dysarthria. It's an inadequate speech. So you give them this list, and they read all these, or they speak it. Now, obviously, they fail automatically if they can't read, if they're aphasic and they can't read. But this is also scored on a 0 to 2 basis. Now, then neglect, extinction and inattention, the last thing. People with, sometimes with the stroke, particularly in the frontal and temporal cortex, they will not, they have what's called neglect. They don't seem to be aware that they have a paralyzed side, or they don't seem to be aware they have a left side of their body, or so they they don't do anything with that. They just completely ignore it. If you put something over so they're not paralyzed, but they won't reach for it. They won't even see it on that side. So we test. Yeah, and you may have gotten the idea that they have neglect while we've done the tests already because they haven't been able to move, or they don't pay attention to the fact that you're trying to do pinprick testing on them. Now, your total score is 0 to 42. Anything greater than 25 is severe neurologic impairment. 15 to 24 is severe. 5 to 14, moderately severe, and less than 5 is mild impairment. If people come in and they have an impairment of 2, so they haven't failed much of anything, even though they probably have had a stroke, we're probably not going to give them TPA. They're probably not going to become a neuro 911 because it's a dangerous drug, has side effects, mostly bleeding and things like that, and that's not much of a defect. People go home with less than 5 and they function at home. Now, a 2-point or greater increase when you do the test again, so an hour, I did the test, they come back from CAT scan, I do the test again, and they're 2 points worse, that shows stroke progression. Now, what does this make a difference? Okay, initial score of 7 was a good cutoff point. A score of 7 or greater than 7, though 65%, almost 70% of those patients got worse if their initial score was 7, which means that you probably needed to treat those people. If they have more than 7, that patient needs to have a rapid evaluation and treatment. If it's less than 7, their worsening rate was only 15%. They give you a little bit more time, and they're less likely to progress to a bad stroke. Less than 5 NIHSS, patient gets discharged home generally. NIHSS of 6 to 13, discharged to rehab because they've got some persistent problem. Greater than 13, discharged to nursing home. You know what that means. Now, with intracranial hemorrhage, more than 20 is a 70% likelihood that this is an intracranial hemorrhage. If it's, and of course we're going to know that anyway because of the CAT scan. If it's NIHSS of less than 20, it's only a 3% likelihood of this being an intracerebral hemorrhage. So when you arrive to the ED, they will do the NIHSS, and based on that, that's your baseline. That's the baseline. They readjust, they recheck it several times, and this also comes in real. If the patient did meet, yes, this can have TPA, then they get TPA, and an hour later, their NIHSS, which was 12 to start with, is now 5 or less. Hey, this is a win. They're getting better. So, okay. Let's take a break for about 5 minutes only while we set up Dr. Basson. Okay, it's my pleasure to introduce in a return visit, Dr. Cerise Basson, who is a neurologist and the head of the stroke program at PCEP Southwest. So she's going to correct many of the things that I told you and tell you all about the stroke program at Peace Health and where we've gone and where we're going and what's happened in the last, some updates on things.
Great. Can you, does this sound okay? I don't hear myself in the back, but can you guys hear me?
Yeah.
No problem? Okay. Thank you, and it's really exciting to be here. It's been 2.5 years, and I remember that because last time I was here I was about 10 months pregnant, and so I'm smaller version, but much more exhaustive version, so please pardon the coffee, but I will be drinking that through the talk. I also want to introduce Louise Jenkins. Louise, you wave. You guys, some of you may know her. Louise is the stroke program manager, and if there are any questions after the talk, things come up. If you'd like us to speak in another forum or closer to home, I know some of you are from quite a ways away, you can get in touch with Louise, and also want to thank Louise for putting together some of the slides that you'll see at the end. And we're going to start with a couple of cases. Actually, we'll start with one case, do a second case in a few slides. But this was Holly the homemaker, who was actually at home with her husband making jam for her friends around the holiday time. And her husband left to run an errand and came back, and the patient was confused. And he called EMS appropriately and came to the ER. Now, this was her initial head CT, which is a normal head CT, and that's what you expect to see probably about the first 6 hours after a stroke. A head CT is normal, and we only give TPA if the head CT is normal. We're not really looking for a stroke or expecting a stroke, but we want to make sure there's no blood. And the story I got, I asked the husband 10 times what happened, that she was sitting in the kitchen. She was just confused. She was just sitting in a chair confused. She hadn't finished making her jam yet. So we go ahead, we give her TPA. She's unable to talk. She's really agitated, but she just can't talk. And within 10 minutes of getting the TPA, she develops, I don't know if you can see here, this huge hematoma on her head. This just giant goose egg is growing in front of our eyes. And said, "Are you sure that nothing else happened?" And he said, "Well, actually, no. What happened was I came in, she was on the ground on her head. I put her back in the chair." So unfortunately, she had pretty much received all of her TPA at this point. And a few hours later, this was her scan. And you can see this white material here is blood, and that's in her ventricles. And probably what happened, she fell. A few vessels burst, and she got TPA, and she developed an interventricular hemorrhage. Fortunately, she was no worse for the wear. She actually didn't get much improvement from the TPA, but she didn't have any ill effect from this, but that's just luck. But my point in bringing this case to your attention is that history is truly everything for us. And you know, again, I tried really hard. I asked every question I could. I asked it 3 or 4 times, and he just didn't give me the history that I wanted. Maybe I wasn't specific enough. But it's where we really depend on you, person in the field who sees what's happening at the home. If you see something odd, if you see that the patient's on the ground, if you see that a lamp is broken, something like that, all of those pieces of information are really helpful for us. The most important piece of information is last known normal time. And as you know, it's a really hard piece of data to get. And the reason is that when you ask a family member, if the patient's unable to talk to you, they're going to say, "This happened at 10." And 10 is the time they found the problem. What we need to know is the last time the patient was normal, not the time they notice a problem. It might be the same time. Sometimes these things are witnessed. Patient's having dinner. They stop using their left side. The family says, "I was there when this happened." But more often than not, the patient went to sleep and woke up with a problem. Or with Holly, someone leaves the house, they come back. So the time that Holly was last normal was the time the husband left the house. We don't know if this happened 30 seconds before he got home or 30 seconds after he left. We have to assume the longest time frame for the safety of the patient. We can give TPA up to 4.5 hours in many patients, 3 hours depending on age, and we'll go over that in a little bit, but up to 4.5 hours. But if someone's out of the 4.5 hour window, it's not really safe to give it. So that's why that last known normal time is so critical. Recent surgeries or medical procedures, and really it's the last 3 months that we care about. 3 months is probably a really long time. That's always been the recommendation, is 3 months. But as we'll talk about in a little bit, the recommendations are changing. You really want to know is, did someone have a major surgery? Not really, did someone, get a paper cut? We don't really care. Did someone have a major surgery? Did someone have a lumbar puncture? Did somebody have anything happen that if you were to give them a blood thinner, they do not have a compressible site? That's really what you want to get facts about. And so you just ask the family, has this person had any surgery in the last 3 months? Hopefully a surgery will ring a bell. Severe recent trauma. And severe is severe. Again, it's not I hit my head on the cabinet. It's, we know what severe trauma is. You were in the hospital, you passed out, you needed surgery, you needed a blood transfusion. We like to know about minor trauma. The lady that I just showed you, she probably wouldn't say she had a severe trauma, but her trauma happened an hour before we gave her TPA. Family contact. This is something that's really tricky. If a stroke patient cannot talk, we really can't give them the treatment they need without a history, and we can't get a history from them. So we depend on their family, someone that knows their history. And what happens is the patient comes to us and their family gets in the car and follows you here. And they're not at the hospital by the time you get there because you go faster than they do. And we sit there and we wait. And they're in the car, so they may not be answering their phone, or they're out of phone range. And we have, on multiple occasions, not been able to treat a patient because we cannot find that family member. So what we usually ask in an ideal world is that the family, someone, the person that knows the patient the best, knows their medical history the best, to stay at home with the phone. It's really hard to tell a family member that, and we get that. They want to be with their loved one in the hospital. But they're going to be the most helpful if they stay at home by the phone until someone from the ER calls them and says, okay, you can come in now. Because we can't do anything without history if a patient can't talk to us. And then a complete medication list. Obviously, if you can get that when you're at the house, sometimes people keep it on their fridge, in their purse, whatever. And if there's one question you're going to ask, it's, are you on a blood thinner? We do not consider aspirin or clopidogrel, which is Plavix, we don't consider either of those a blood thinner, although it's helpful to know. So if they say, yes, I am, you want to know, what is it? Because if it's aspirin, I don't care. But blood thinners, for obvious reasons, make us very worried. We don't want to give TPA, which is one of the strongest blood thinners known, to someone who is on a strong blood thinner. It used to be really easy. The only blood thinner that we knew about was warfarin or Coumadin, and we never give TPA if the INR is greater than 1.7. So a patient would come in, we would check an INR, 1.8, great, we're done, you can't get TPA, or 1.6, we're in business. But now there are a number of other blood thinners, and we can't easily test for them. So these are the ones that you will most commonly see. Eliquis or apixaban is the new favorite for atrial fibrillation, stroke prevention, atrial fibrillation. Pradaxa, still a lot of patients getting Pradaxa out there, but becoming a little less popular. And then rivaroxaban or Xarelto. Sometimes people are on these for other reasons. DVT, PE, someone had a knee replacement, hip surgery. Sometimes they're on these for a week to prevent a DVT and a PE. But Eliquis is becoming more and more popular as the first line for prevention of stroke with atrial fibrillation. These are the sample packs. Okay, so sometimes someone, they haven't really started it yet, or they just got a dose from their doctor. And I want you to take a good look at these, because if you see anything like these around the house, please bring them in. Please just grab the package and bring it in. It's really, really helpful. Again, there's no quick blood test. There is a quick blood test for Pradaxa. It's called a thrombin time, and we can check that pretty quickly. But if we don't know the patient's on this, we would never check a thrombin time. It's really expensive. It takes a while. It's a special test. If we know, then we would check it. If the thrombin time is out, we can't give TPA. If they missed their last 10 doses, then we can give them TPA. But Eliquis, Xarelto, Pradaxa, there's no generic yet for these, so that's why I'm using the trade name. Almost all of them have an X sound in it, if you want to get that right. Several of them are 10A inhibitors, so, and Pradaxa is a direct thrombin inhibitor, but these are both apixaban, rivaroxaban, have an X, very clever 10A inhibitor, so Roman numeral 10. But again, please keep your eyes open for these. It is critical information. All right, so TPA. TPA is still the only FDA-approved medication for acute ischemic stroke. It's been years and years and years. It's kind of crazy how the cardiologists have developed a whole handful of other things they can use. We still really are left with TPA. The packaging is changing for TPA. There are a number of reasons. There was a law that came out, I don't know, about 10 years ago now, but it's now finally becoming effective, and that is that all drugs have to have the same format of labeling. And so their contraindications have to be proven contraindications. They are truly proven reasons that you cannot give a medicine, not just reasons that were not used in the trial. So this is the list that Genentech, who makes Activase, or this is the generic name for TPA, say you cannot use TPA in these situations. Current intracranial hemorrhage, obviously. If you have blood in your head, do not give this blood thinner. If you have a subarachnoid, active internal bleeding, recent, again within 3 months, intracranial or intraspinal surgery or serious head trauma. And then it says this very vague thing, presence of intracranial conditions that might increase the risk of bleeding. That's sort of whatever you find to be an intracranial condition that increases the risk of bleeding. Bleeding diathesis, which they say is a platelet count of less than 100,000, and severe uncontrolled hypertension. So you can count 1, 2, 3, 4, 5, 6, 7. Only seven things you have to worry about. This is our list. Okay, there's a few more than 7 there. I didn't count them all up, but the reason why all of these things are on here is we want people to think about them. We have a caveat here. We feel really strongly about this, and this says, with careful consideration of risk to benefit, patients may receive TPA despite 1 or more contraindications. And that is because sometimes we have patients that come in, for example, who maybe did have a stroke 2 months ago, and that currently is stroke in the last 3 months. And they'll say, the family says, you know what, this is such a devastating stroke that I know my mother would rather have a head bleed and die than live like this. And we'll talk to them and have a really serious conversation, and sometimes we'll give the medicine. Or sometimes blood pressure is above 185 over 110, but we give them some Labetal and it comes down. So we want to go through each and every one of these points to make sure we understand the risk and we can explain them very confidently and thoroughly to the family and the patient. But that list is getting smaller and smaller, and probably for good reason. This list is so long because when the initial study came out, I think it was 96 or 98, that proved that TPA is effective. It was a study. So it was a big multi-center study, and they wanted the results to look good. So they said, anyone who's had a stroke in the past 3 months, they're not going to look good anyway, so we don't want to put them in the study because we don't know how that's going to look. Anyone older than 80, we're not going to treat patients older than 80. So that's that's why you might hear about the package insert changing. Patients that can get TPA after 3 hours, 3 to 4.5 hours. Patients who they have to be less than the age of 80. They cannot be on any oral anticoagulant. So let's say they're on warfarin, but the INR is 1.5. Theoretically, the rules say you can't give those patients TPA after 3 hours. If they have a really high NIHSS, so that score greater than 25, and history of both stroke and diabetes. If they've had stroke and they have diabetes, they're not supposed to get it. Totally arbitrary. Again, it goes back to how that study was performed. They took those people out because the results probably wouldn't have been as good. We've had many cases where we talk to the family and say, you're 82. This is an arbitrary number. It's 4 hours. What do you want to do? But those are the recommendations. All right, any questions about those things? We'll go on to our second case. All right, so this is Terry the teacher. Some of you may have heard of this case. It was in the newspaper, but in the interest of confidentiality, I won't say any more. This is a young lady. She was 40, teacher, worked for the school system. And she's in her office talking to a student actually about college plans, and suddenly can't talk. And then becomes unable to move. She's sitting in the chair and she can't talk, she's staring, she cannot move anything. And this sort of came and went. Then she would start talking again, and then she'd be able to walk, and then she couldn't move, and these sort of fluctuating symptoms. And the student actually immediately was the one who said, something's not right with this lady, went to the school nurse. Had to be carried into the front lobby where EMS was called. And in the ED, she's perfectly fine. She says, I don't know what happened. I couldn't talk, I couldn't move. She walks to the bathroom, she comes back, and then she does it again. And she's just acting really weird. She goes to get a CT, she becomes comatose, stops breathing, and gets intubated. She's totally healthy. She has no real medical problems. She does see a chiropractor for neck pain and had a neck manipulation. She said the chiropractor had cracked her neck some point in the last few months. Otherwise, is a really healthy person. This is her head CT, and it really, on first pass, looks totally normal. There's no blood. For those of you that aren't familiar with looking at head CTs, you have to sort of reverse it in your head. This is the right, this is the left. It's like you're looking underneath the patient up. So you have to reverse here the eyeballs, the sinuses, the back of the head. And this is the basilar artery. What looks bright white on CT? Density, right? So, heard a few murmurs over here. Bone and blood, right? Bone and blood. And that includes thrombus. So a blood clot looks bright. So here's bone, this is just the base of the skull, and then this nice bright white dot. Someone who's 95 years old with a lot of calcium in their vessels might look that way too, but you'll look at other vessels and they also look bright white. Someone who's 40 and healthy and doesn't have any risk factors, it's subtle, but their basilar should look like this, which is essentially the same color as the brain. This looks the same color as bone. Okay, I don't know if you all can appreciate that or not, but that's a really scary sign in someone with these symptoms. You have a young person with neck pain with this fluctuating history of, I can't talk, now I can talk. I can't move, now I can move. And you can't really put it together. You know, it just seems weird. Why is your face weak, and then your arm weak, and then your leg weak? You always have to think of the basilar artery. This is a normal scan. This is the basilar artery right here along the base of the brain, and this is this lady's scan. There's no basilar artery. It's gone. And basically was filled with clot. So why does clot in the basilar artery give you these problems? Well, here's a picture of the basilar. I had to take this from the internet, so I apologize about this background. But here's the basilar artery, and you can see the basilar artery comes up here, the vertebral arteries, becomes the basilar artery. And I like this view. It shows you, here's the basilar artery, and off of the basilar artery are these what's called the perforating arteries. So these little tiny arteries that come off, and they feed all of the structures in the pons. And what happens is you get a clot here in the basilar artery, and you start basically picking off these tiny little vessels in a very random fashion. Okay, so you might pick off this one, and it hits your corticospinal tract, so you get a leg on one side becomes weak. And then as this clot starts sort of moving up, becoming bigger and bigger, you're going to pick off another one of these little tiny arteries, and maybe you'll hit your facial nerve on the other side. And you'll pick off another one and your abducens nerve, so now your eyes aren't tracking perfectly. And then maybe you'll get the trigeminal nerve, so then your face gets weak, and it's maybe on the same side as the leg, maybe not. And your face gets sort of numb on one side, and now you're dizzy and you're incoordinated. But that's the reason why basilar artery strokes are so confusing, is because it's not, there's a lot of pathways in this tiny, tiny space. And depending on which of these minuscule little perforating arteries you pick off, you can look like you're having an MCA stroke, or you can look like you're totally crazy. And usually they are young people who have no risk factors, and they are thought to just be kooky. So you have to have a very high index of suspicion. And usually it starts with, this is a bleed in the same location, but you get a little, probably say this is a little stroke here, so you just are weak in a leg, and as it gets bigger and bigger and bigger and bigger, you get more and more systems involved. This is always, as you know, a very worrisome sign. I call this the creepy uncle sign, because I had an uncle that always looked like this. This is called a skew deviation, okay? So this is a disconjugate gaze. Disconjugate gaze, specifically skew deviation, is one eye down and one eye either straight ahead or up. That's the skew. It's not one out, one out. It's one down. And that is always, always very worrisome for a brainstem problem, okay? You have a patient that things are just not making sense, and they're comatose, and you open their eyes and you see this, one eye down and one eye not down. Be very, very worried, okay? This is something is going on in this person's brainstem, unless the family says they've always looked like this, so don't worry about it. That's just Bob. Bob's got those weird eyes. Okay, so this is this woman's arterial. She got TPA. Okay, so this woman is recognized she's having a basilar artery stroke. She gets TPA, and then she actually went to the cath lab. And the reason is that basilar artery strokes are so devastating. They can, as you know, lead to locked-in syndrome. If you completely blow out your pons, what happens is you are awake, you're alert, you cannot move. So you are locked in. It's really the most neurologists and most people, most of humanity considers this the worst of all potential outcomes. And so we will do everything for these patients. It doesn't matter if they're 4.5 hours, 8 hours, 24 hours. Unless there's a really good reason that we are going to hurt them or the damage has been done, we will do everything to make these patients better. So she got TPA, then she went to the cath lab. And what was interesting is here, by the time she got to the cath lab, her basilar was open. The TPA worked. And you can see here, these are the vertebral arteries right here. They join up to become the basilar. Here's her basilar. Here's her vertebrals. You can see the problem actually started here. You can see both vertebrals have little missing chunks. And what happened to her is she had vertebral artery dissections. So a tear in the wall of the blood vessel, maybe or maybe not from the chiropractic manipulation. We do see, I don't know, once or probably 3 or 4 times a year, someone who goes to the chiropractor, and it's always with that very quick rotation, getting your neck cracked. And in some people, we don't know why, they go to a chiropractor 100 times, the 101st time, say, that was just really bad. I don't know, it was really painful, and my neck's been hurting ever since then. And their vertebral arteries tear. We actually had a young guy came in, this is about 6 months ago, he had the same problem. He had a vertebral artery dissection, but his anatomy was such that he developed a clot, but it went back down. Instead of going up the basilar, it went back down this anterior spinal artery, and he had a stroke in his spinal cord. So that's also an interesting sort of factoid. If you have time to ask the patient, you think has a posterior circulation stroke, have you had any neck trauma? You know, did you get into an accident? Did you go to see a chiropractor? We had one case, it's not funny, but a guy who was doing shots with his friends over and over and over again. And this is what happened to him. He turned out just fine. But anything that makes you think about quick head rotation. Yeah, so be warned, all of you. Okay, so let's say a person has just the vertebral artery. Just the vertebral artery is involved and not the basilar artery. Usually what happens is this is the pica, posterior inferior cerebellar artery. That's the first one to get nicked off. And what you'd see is what's called a Wallenberg syndrome. So the vert doesn't go all the way up to the pons, but you kind of just get right there in the medulla. And again, a lot of real estate there. I like this picture. It shows the fibers coming down from the brain, crossing in the midbrain, coming down. And here's the medulla. This yellow triangle here is the stroke. And you can see what you're ticking off. You have vestibular nuclei, spinothalamic tract, so pain and temperature, nucleus ambiguous. That's why these patients obviously kind of hoarse. They say my voice sounds weird. Inferior cerebellar peduncle is back here. And so these patients, what's confusing about these patients is they'll say that I have one side of my body, my arm and leg feel kind of numb, but what's weird is my face on the other side is sort of numb, and that's because of the trigeminal. So where is that here? I can't see where blue. Someone else might be able to see it, but here it is. Kind of comes down all the way here, the trigeminal tract, so you get face on one side, body on the other side, and these are also patients who people say, that doesn't make any sense. It has to be all on one side of the body or you're just kooky. You're making this up. There are parts of the body that you get these cross signs, and if you're not thinking about this and not looking carefully, you can miss it. All right, drip and ship. How many of you actually take these patients from one hospital, they got TPA, to another? Probably all of you. Anyone who's EMS, maybe? Okay. So frequently we'll have patients, I know locally we'll have patients from Longview that they get TPA, then they come to us. Or sometimes we give patients TPA. We might be dark, so we don't have anyone in our cath lab any particular night. We have to move a patient to OHSU to get to their cath lab. So a couple things I want to mention for drip and ship. Drip and ship, again, means someone got TPA. You have to move them to another hospital while the TPA is still running or shortly after the infusion has stopped. I know there is, Dr. Whitwer, wherever he is, I don't know where he went, there he is in the back. There is a protocol that you all have for drip and ship, but a couple of things I wanted to note, or one big one, is allergic reactions to TPA are very, very scary. They are totally unpredictable. Less than 1% of the time this happens. It can be associated with ACE inhibitor use. It usually happens within the first 15 minutes of the infusion, but it can happen minute 59 of 60. This is obviously the scariest, is this angioedema. And for whatever reason, in stroke patients, sometimes it's 1/2 of the tongue. Doesn't make it any less dangerous. But you want to ask the patient, are you feeling any tingling? Are you feeling tongue swelling? If you think your patient's slurred speech is getting worse, have them stick out their tongue and make sure it's not this. They're not having an allergic reaction to the TPA. And then hives, urticaria. We had a patient 2 weeks ago. Everything was going great, and he developed hives from his waist to the top of his head. Horrible, severe allergic reaction. And your protocol would be the same. Whatever you would do for someone with anaphylaxis, angioedema, you do the same thing, and obviously you stop the TPA, okay? Stop the offending agent. So we've had a couple of patients that were shipped. They said, yeah, their slurred speech was getting worse and worse and worse. This is what was happening. Okay. All right. We have a few minutes left. I want to thank Louise put these slides together. These are our data. We were asked to share what our numbers look like. These are our stroke volumes. You can see up here, this is January through December of last year. We had 617 total stroke patients. That is a ton. That's up there with major academic centers. Ischemic stroke, you can see the numbers per month, but always ischemic stroke is higher than hemorrhagic stroke. And TIA sort of fluctuates. Sometimes it's more, sometimes it's less. Numbers do fluctuate a little, but we're seeing about 30 to 50 patients a month, which is quite a lot. Okay, these are stroke codes, and what Louise did here was pretty cool. These are what you call in as a code 3 stroke is blue. We have a protocol called 911 upgrade. Patient comes in as a code 3 stroke. They get to their room in the ER, and the ER physician is at the bedside either by the time the patient moves from the rig to the bed or within probably 2 or 3 minutes, and they evaluate the patient. If they say, yeah, this is a patient that could get TPA or go to the cath lab, they call out a code. It's called a 911 upgrade. That is received by the neurologist, the cath lab physician, the entire cath lab team, the radiologist, the pharmacist. Everyone knows this is the real deal. Patient, if there are patients on the CT table, they're moved off the table to make an open CT table. Pharmacy calls, says, what's the weight? They pre-calculate the TPA. They don't mix it, but they pre-calculate the dose. The neurologist calls back within 2 minutes, and the ball starts rolling. So the point of this is that you guys are doing a phenomenal, phenomenal job of calling these right. What you don't want to see is down here that they're not being called. They get to the ED, and the ED physician says, oh my God, this is a stroke. We didn't know. Definitely want to overcall. A lot of these are strokes. They're not incorrect calls. It's just they're not patients that we can do anything about. Their stroke is either too old. There's some other reason they can't be treated for their stroke. But these numbers look exactly how we would like to see them. So here are the stroke codes. I'm sorry, the code 3 strokes. These are our 911 upgrades in red. And in green are the patients that actually receive TPA. You can see a small percentage of those 911s actually get TPA. Some are bleeds, some are drug overdoses. You know, you can imagine the reasons why, but these are the percent of stroke codes receiving TPA. So it's about, you know, varies month to month, but up to 34% of the stroke codes that you guys call get TPA. That's huge. That's huge. So anyway, we want to congratulate you. You guys are making our lives much easier, making the patients' lives much better by calling those when you see them. These are our acute interventions percent, and this is sort of a 3/4 of a year, January through October 2014. These are the numbers of acute ischemic strokes that we get in. Again, these are 3-month blocks, and this is just 2 months. We don't have the data full yet from December. But you can see 119 patients. This was a banner quarter. But 70 this so far in October and November. These are the patients neurointervention. By neurointervention, these are patients that go to the cath lab. Few of the patients go to the cath lab. Few patients get TPA. But overall, between 10 and 20% get intervention. And again, we think that is actually pretty similar to major academic centers, having 20% of your patients with stroke getting interventions. Let's talk about the cath lab. We had some questions about how do we know who goes to the cath lab, who doesn't go. There have been many studies showing that patients greater than the age of 80 do not do well when their stroke is treated in the cath lab. And what can we do in the cath lab? We can give TPA directly into the clot. We can suck the clot out using a vacuum. You can use a little corkscrew, pull the clot out. Sort of the favorite device now is called a Solitaire. Sorry, Mercy's the older version. Solitaire. Solitaire is a stent. So it's called a stent retriever. The way it works is you go in, you can put it past the clot, and then deploy the stent. So it opens up, and the struts stick in the thrombus, and it stays there for about a minute, and then the entire stent, open, is pulled out with the clot hopefully attached to it. Couple nice things about it. Number one, once your stent is open, you have blood flow. Okay, the old devices that were aimed on pulling the clot out, either vacuum or the little corkscrew, you don't have perfusion until your vessel is open. These new devices, if you can get it past the clot and open it, your vessel's open. Okay, so they are immediately restoring blood flow. Doesn't always work. You can't always get past the clot. You can't always get the clot out. But our results have been very, very reassuring that this is the technology that we want to use. Greater than the age of 80, study after study have shown those patients overall, as a group, do not do well. So our criteria are basically if a patient comes in and they are less than the age of 80, they will get a CT scan and a CT angiogram. If that angiogram shows a clot, they go to the cath lab. If the patient is over the age of 80, they do not get a CT angiogram. Sometimes you get a really robust 90-year-old. They are totally normal. They have no risk factors. They were golfing an hour ago. You get a CTA. You make a decision based on the patient. But overall, that's our protocol. Less than the age of 80, they get a CTA. We consider going to the cath lab. We have physician call coverage for the cath lab about 85% of the time. We have 3 physicians working on a 4th one getting trained that take patients to the cath lab. We have a transfer agreement with OHSU. We are never dark for stroke because most of the time our strokes can be treated with TPA. So we give patient TPA, we decide they need to go to the cath lab. If we're dark, we will send them to OHSU. We talked about what you can do in the cath lab. This is in last year. For 3/4 of the year, we did 21 cases in the cath lab. This was pretty awesome. Almost 70% of those patients either went home or to rehab. This is a huge difference if you looked at these numbers the year before, and a lot of this is because of the new technology. Again, opening that vessel early, getting blood flow early, makes all the difference for these patients. 14% of these 21 patients went to SNF, 10% went to comfort care or hospice, and 9% died in the hospital. This is our overall program data. These are the percent of stroke patients discharged home. Red is hemorrhagic and blue is ischemic. You can see here it changes a little bit per month, but about 50% or more of our patients are being sent home. Hemorrhagic stroke varies month to month, but up to 70%, which is great. Mortality rate for ischemic and hemorrhagic stroke, you can see, again, varies. Sometimes 0, that's a good month. Sometimes it looks really bad, but it just varies month to month. Sometimes you get a month where you get, and they're all NIHSS of 30. We like to look at the trends overall. These are numbers that we follow very closely. These are the readmit within 30 days. Ischemic stroke, the number we try to get below is 8, right, Louise? 8%. You see here we had some rough months, 14%, 16%. That's numbers that we don't want to see, but overall we're looking right around 8%, 2%. So, and then hemorrhagic strokes, 0 readmit. As Louise mentioned to me, those patients often, we have only a few patients and they die, so they're not going to be readmitted, but anyway, 0 still looks good. And stroke average length of stay, ischemic stroke average length of stay across the country is 3.5 days, and hemorrhagic stroke length of stay is more. I think it's 4.5 or 5.5 days. I don't know for sure, but we're staying pretty close to that. We don't push patients out of the hospital. What we don't want people to stay unnecessarily. They get bed sores, DVTs. They're not getting the rehab they need once they leave the hospital. And so we want patients to be where they can rehab the best, and that's not usually in the hospital. So we do watch this number carefully. we're doing a pretty good job of getting patients to where they need to be to improve from their stroke. And that's it. What questions do you have? Go ahead.
So with traumatic brain injury, bleeding and recovery, are they still at a high risk for the other condition, like a primary stroke also? Or
You mean someone who comes in,
they
they,
had a TBI with a bleed,
like
Is that
years
considered-
ago?
sure, or whatever. Yeah.
Uh-huh.
Are they at a higher risk yet for another?
Probably not. Probably not. If it was a bleed from their trauma, probably not. It's just an isolated event, assuming they didn't have any vessel injury, thing like that. What we want to know is someone have a severe TBI, you know, very soon to having their ischemic stroke that would make you worried about giving TPA. Yeah, not usually. What other questions do you have? Think about our program. Nothing? Marty? Anything?
No, it's excellent.
Okay.
The history, like Dr. Bassett said, is really critical, and I just want to emphasize that. The timing of the event, just for us in the ED, as far as making these critical decisions and activating. It's a big consequence to activate this system because it gets a lot of people involved. So we take it very seriously, try and do our due diligence, and you guys really help us with that accurate history. So whatever you can do to hone in on those essential elements is really important. The NH stroke skills score that Lynn was talking about, we use that as a tool, and we kind of monitor patients over time, so we can use this as an index for how we're doing and how patients are improving. So I think life-changing, life-saving for people, so these are big decisions.
I should mention that Holly Homemaker, she did not do as well as we had hoped. She came in not able to speak. She got a little bit of her language function back, but not what we had hoped for. And Terry, the teacher, did phenomenally well, had a big stroke in her pons, but after a couple days was essentially normal and very little deficit and is just doing awesome. So thank you to all of you for your hard work, and you, again, make our jobs easier and you make the patients' lives infinitely better. So thank you so much. And yeah, be careful at the chiropractor.
Can I throw in something? I just want to give you a heads up that we're working on a process improvement right now at the hospital. And one of the things we're working with Dr. Whitwer is a direct to CT process. So you'll be seeing this come in. We're working on the process where the patient would be, you bring them in, code 3 stroke, and they wouldn't leave your gurney. The doc would meet them somewhere. We haven't determined where. Give them the quick once over, roll them to CT on the gurney, get them on the table, and then you guys would be able to leave. So we're working on that with Dr. Whitwer. So more of that to come. Just want to give you a heads up.
Okay. Well, any other questions for Dr. Basson or for Louise? Okay. Oh, a question. Thank you.
There is no age limit to TPA except in that extended window. So the recommendation for that 3 to 4.5 hour window is less than the age of 80. But for the traditional 0 to 3 hours from the last time you were normal, there is no age limit. We've given it to patients over the age of 100 many, many, many times.
So for all of us, they could go code 3 and let you guys take it.
Absolutely.
Yep.
I'll always go code 3. Do not let age be the decision maker. Absolutely not.
Thank you.
Okay, we're going to set up for case reviews right now. Thank you. Marlo? She lost the little fuzzy thing. Don't worry about it. Here's the...
Can you hear me clearly in the back? So just a few case reviews. We'll review the criteria for some of the ongoing studies, and then we'll be done. So case number 1 was the crews who dispatched code 3 on a CVA, and it was a 55-year-old woman, 80 kilograms, lying on the floor, ABCs intact, with obvious left-sided paralysis. The roommate thinks she was walking around about 3 hours previous, and a history of a remote prior CVA. So this is the documentation provided, very appropriately documented the time last seen normal, the GCS, EKG and blood glucose. And so transported code 3 is a stroke alert with some slight improvement in the left-sided droop, left-sided movement, and facial droop. So in the hospital, was found to have an acute ischemic stroke in the right MCA territory. Once some additional history was gotten from the bystanders, just determined to be barely outside that TPA window. And then with the CT angiogram, it was discussed, just too far to be intervened on. Was a Kaiser patient, ultimately was transferred to Sunnyside for additional care, but ultimately did well. But again, as you've heard multiple times today, emphasizes the critical importance of the history, getting bystanders who can provide as much history as able. This is, you can see this is one of those, that small number of cases not amenable to intervention just outside the TPA window. Case number 2 was a 55-year-old woman complaining of difficulty breathing, with asthma attack, but the crew arrives to find that the patient is pulseless and apneic. And so CPR was started immediately. This was also a very large patient in a small place. And so continuous CPR, placement of the eye gel. And so but even with a large patient, the initial resuscitation was able to be done with the eye gel. Patient was able to be oxygenated and ventilated, and then return to spontaneous circulation. Appropriately, eye gel removed, ET tube placed to get a secure airway, given that the patient was still obtunded. And then transferred, got some ongoing sedation, some treatment for reactive airway disease, which was probably at least a contributor to the arrest, but still comatose. So assisted ventilation. You can see that initially the eye gel for intubation, and then visualization documented very high end tidal CO2, consistent. So this is a patient who's going to be have a severe respiratory acidosis because of an obstructive process. So very acidotic, and also hypoxemic. But you can see with the ventilation, CO2 is coming down, pulse ox is coming up, and then appropriately for large patient, padding under the shoulders. It's not specifically documented here. Remember that keeping the nasal cannula on a patient like this who's hypoxemic is going to give you more time to get the tube. And then verified, continuous CO2. You can see that with this intubation attempt, because you've got this patient who is breathing and the breathing stops, then tidal CO2 goes back up. So these are patients that, especially patients like this that are very acidotic, they're at high risk for rearrest when you're reintubating them. So it's important to keep that time as short as possible. You can fix the hypoxemia with the cannula, but that doesn't fix the respiratory acidosis. But then good bagging, getting closer to eucapnic with an end tidal CO2 of 35, but still a GCS of 3, some sedation, and then maintaining this around 30. In this case, you want to be permissive, but somewhere in that 30 to 35 range is where you want to keep a patient like this. But as you're doing this, you're fixing their respiratory acidosis. Patient had a normal echocardiogram, normal cardiac markers, was able to give additional history. So the reactive airway disease didn't help, but neither did the methamphetamine. But then did have some rib pain after CPR. I think that's probably a fair trade-off. But was discharged on day 10, CPC1, so that's cerebral performance category 1, meaning essentially back to baseline level of function. Questions about this case?
Back to normal methamphetamine.
Yeah, back to but it's very, very well managed in the pre-hospital setting and clearly a safe. So case number 3 was a 58-year-old man with a sudden onset of chest pain and dizziness. Had some similar episodes before, but they all went away on his own. Sitting in a parked car. GCS 15, but hypotensive, ventricular tachycardia on the 4-lead EKG, and so given Versed and cardioverted at 100 joules. Then again, given Versed, cardioverted at 150 joules, goes into cardiac arrest, defibrillated, non-synchronized 200 joules. But then, as the crew is attempting to support his respiration, still has gag, unable to take an oral airway, still in ventricular tachycardia. So, given the first dose of ALPS, shocked again, now starting to have some movement, GCS of 8, shocked again, and then given ALPS number 2. Again, another shock at 300, and then IGEL, the attempted passage at the IGEL, but patient was gagging at this point. Hypoxemic with an end-tidal CO2 of 44, but then now, after this, now in a sinus tachycardia. And so here are some of the strips, and then GCS rapidly improving. So, and then here are some of the strips, and then what he ultimately came to. So this patient had an inferior wall STEMI, and remember with the inferior wall, that's where you're getting so you see someone who's hypotensive. There's a large amount of myocardium at risk. This is not an uncommon presentation, and an occlusion of the circumflex artery. It was very small. They were unable to revascularize it, so he's managed medically, had dual AICD placed, but he did well and was discharged 6 days after admission. This guy seemed to improve pretty rapidly during the pre-hospital course. You can consider RSI if you've got ROSC, but the patient's still gagging and comatose. But if he's rapidly improving, you can manage him without an invasive airway, as the crew did here, and you did very well. Okay. So reminders about the ALPS study. So we're doing it for non-traumatic out-of-hospital cardiac arrest. Known a exclusion criteria, open label, IV amiodarone or lidocaine. If the patient is taking oral lidocaine, that's not a contraindication. Remember the protected populations and anyone with a no study bracelet. So this is a question that's come up. So anything that the patient had on them when the arrest happened, so an ICD or a life vest, that does not count as a shock. So an AED shock, a shock delivered by any EMS personnel does count as a shock, but ICD and life vest do not count as a shock because we don't know what that initial rhythm was. Questions about that? And so the goal is to give the study drugs within 10 minutes or less after arrival. Remember, it can run in the same tube with epi. So only for tiny patients, you're giving just syringe 1A. Otherwise, you're giving 1A and 1B. And then calling the enrollment number. I was just talking with one of the cardiologists about this. I mean, they're very excited, even for their in-hospital practice, to have the results of this study. Coming into what's hopefully the last year of this study, we're still in the metro area, by far the leader in enrolling people. So the hope is so we're going to wrap up the data collection, and then within the next year or two, finally have an answer to the question of what's best to treat this. So your work has been critical to do that. It's very important to download the CPR process file and notify the code. Notify the team about the ALPS kit number. And then finally, the sudden unexplained death study applies to the transporting agencies, and this involves drawing blood on patients who have sudden cardiac arrest. This does apply if you get ROSC. Just the only addition to the ALPS exclusions is that overdose is not included in this. And this is looking for the genetic markers so we can predict who's at higher risk for sudden cardiac death. The tube gets labeled, and then ultimately should make it back to the headquarters of the transport agency. And that's all we have. Thank you very much.
Great. All right. Next month is Skills Month.